Welcome everyone. Good afternoon. Welcome to our last session in the Connecting the Dots webinar series. We end with a bang. This is a special session with some really big names in sickle cell disease, medical research and management. Right? I'm excited. This has been a great series and I hope you have benefited from all the information shared. It has really been inspiring and amazing for me. So I hope you all had a similar experience. We will go right into it. I will introduce Mr. Kieran Blackman, the champion behind the series, and I'll allow him to share the concept behind this special lecture in honor of Dr. Waveney Charles and how we will move forward with this. And then afterwards, we will proceed with the introduction of the team, the panel.
Okay, well, from the time we started planning the events for World Sickle Cell Day, well, Mr. Young was the first person to suggest that we should do a 3-day webinar series, right? But he also, I was given a mandate that whatever we do, that we must remember or find some way of remembering the legacy of Dr. Charles. And I thought to myself that what other way could we do that besides having something that we could do every year, right? This year we might do it for World Sickle Cell Day, but next year we could do this for hemophilia, we could do it for thalassemia, because we are an organization that represents a number of different blood disorders. And she cared for us all. She has been responsible for saving many lives, right? Many of us who are active participants in the society admit that at some point in our lives that she has been responsible for keeping us here and keeping us going. So I thought that we can have an annual lecture in her name that will memorialize her name, right? And every year we could try to do something different with it, right? So her legacy will remain, right? So the idea of the distinguished lecture came out. But I also thought that gathering a panel of speakers would make the lecture more interesting than persons just think they come in to hear about one topic. So having a discussion after will make it more interesting, right? It will get a lot more discussed and covered, right? So that was the idea of bringing this panel together to have this discussion. So the idea is that Dr. Olayemi will give his lecture. We will have a short little break, make some announcements of some of the things that SISB is doing soon, and then we will proceed to the discussion. So we will ask each one of the members here to, on the panel to make a short give a short discussion on something that some aspect of sickle cell that they want to speak on, or some aspect of the lecture that they found important, right? Something of their choice, right? And then the discussion starts from there, and persons in the audience can ask questions after each one of them has gone.
All right, next we'll have some welcome remarks by the president of the SISBD and chair of GASTO, the Global Alliance of Sickle Cell Disease Organizations, Mr. Issa Ali.
Thank you very much, Renee. Our distinguished panelists, ladies and gentlemen, a pleasant good afternoon to each and every one, and welcome to SISBD Connect the Dots webinar series, our final lecture in that series. I also want to take the opportunity to wish the STD community home, Trinidad and Tobago, in Jamaica, in Ghana, happy World Sickle Cell Day. And as I would have just given remarks a short while ago at Gasto's webinar, where I used the English novel, Charles Dickens, where he said, in A Tale of Two Cities, where he said, it was the best of times, it was the worst of times. And we're in the middle of a pandemic, COVID-19, and we most definitely experiencing the worst of times, but at the same time, we could still experience the best of times. And right now in Trinidad and Tobago, on our streets, usually on June 19th is World Sickle Cell Day, but in Trinidad and Tobago, it's also Labor Day. And so we are accustomed to all these marches and celebration of the labor movement. Unfortunately, because COVID-19 is raging here in Trinidad and Tobago, and our numbers are the highest, our deaths are the highest, it's not the best of times at this point. It's actually the worst of times. But at the same time, we could still make this thing work. And the thing of it is the COVID-19 has had a global impact. It's not just touched Trinidad, it's not just touched the Caribbean, it's touched the entire world. But what COVID-19, this period has given us, it has allowed us time to stop, to reflect, to rethink of what happened in the past, to give us an opportunity to determine our shortcomings and how we could really move forward and how we could improve our future. And, when we look in Trinidad and Tobago, and we see the challenges that we have to face with COVID, it is very, very difficult to maneuver at this point in this last couple of 6 weeks, month. It's been very difficult. It's been very difficult to go to the groceries. It's very, very difficult to come out of the houses because of the fear of COVID-19. And these challenges take place in the last 2 months in Trinidad and Tobago. It's been very, very difficult for us. And we experience a lot of daily challenges. But when we talk of daily challenges, you really have to look at the STD community and the inherited and severe blood disorder community, where the nature of inherited blood disorders, the nature of STD, has made, they have to deal with the daily challenges and obstacles every day. They know how to deal with challenges. They know how to deal with obstacles every day. And the nature of STD and inherited blood disorders has made our members resilient, made our members tolerant, determined, and patient. And these are some of the values that will allow the globe and the world to deal with this pandemic. So I want to take the opportunity at this point to thank the organizers of this Connect the Dots webinar, led by, and I'll call him the Honorable Kyron Blackman and the Honorable Tony Alexander. These two young man, young lady, has led us into, I was explaining to him before, that this is one of probably the best World Sickle Cell Days that we have seen ever. It was well planned, it was well executed, and the late Dr. Waveney, Patricia Charles, would have been so proud to know that the young ones of the organization she started some close to 40 years ago can now take the reins and take it to a level that she would have always wanted it. And I think wherever she is, she'd be very proud that the young ones in this society, the young ones who actually would have sat in her lap, would have cried on her lap, would have run around like little babies, are now stepping up to the plate and are now leading the SISBD. So I think it's a very, very proud moment for all of us. And to see the panelists assembled here today, I think it shows the level that our members are.
Well, we need virtual space, so this happens.
Okay, I think he was wrapping up. So we will move right ahead. I will introduce the panel. Our featured speaker today is Dr. Edeghonghon Olayemi. I'm sorry if I pronounced that incorrectly. All right, he is the consultant hematologist to the Ghana Institute of Clinical Genetics. We're the largest clinic dedicated to the comprehensive management of sickle cell disease in Ghana is located. The clinic has records of over 25,000 patients and attends to about 40 to 50 patients a day. He is also a consultant hematologist to Kolebu Teaching Hospital, which is the premier and largest teaching hospital in Ghana. The hospital serves as a teaching hospital to the University of Ghana Medical School, where he is an associate professor of hematology and immediate past head department of hematology. He has specific and specialized training as well as experience in the care of patients with sickle cell disease. He has worked in sickle cell clinics in Nigeria and Ghana and published widely in the area of sickle cell. In September 2015, he introduced the routine use of hydroxyurea for the management of adolescent and adult patients with sickle cell disease to the Sickle Cell Disease Clinic in the Ghana Institute of Clinical Genetics. He is the site PI for a phase 2B clinical trial evaluating the efficacy of IMR-687 in subjects with sickle cell disease, called Ardent. He is also the Accra site coordinator and deputy director, training of the NIH-funded Sickle Cell Disease Genomics Network of Africa study, for which he had led a team to recruit over 1,500 STD patients as at the end of 2020. He is a 1994 graduate of the College of Medicine, University of Ibadan, Nigeria, a fellow of the West African College of Physicians, and a fellow of the Higher Education Academy in the UK. He holds a Master's of Science in Medical Education from Cardiff University, Wales. Let me just allow you to see. Yes, Professor Olayemi. You can see him there. Also, we have Professor Isaac Odame. If you are in the sickle cell community, you should know his name. He is the Professor of Hematology Oncology at the Department of Pediatrics at the University of Toronto and the Hematology Division Director in the Department of Medicine. He is also a staff physician and medical director of the Global Sickle Cell Disease Network at the Center for Global Child Health at the Hospital for Sick Children, Toronto. I wouldn't go into too much detail, but needless to say, we have deep respect for you, Dr. Odame, and welcome. And thank you for continuing to have such a good relationship with us here in Trinidad and Tobago. Next, we have Dr. Monika Asnani from the Sickle Cell Unit in Jamaica. She is a professor of family medicine and epidemiology, right? And also Dr. Kenneth Charles, our local consultant hematologist and also a senior lecturer of hematology at the University of West Indies, St. Augustine campus. Welcome. We have really impressed with the lectures you all have given in our series. Thank you for participating, Dr. Asnani and Dr. Charles. And now we will get started. Dr. Olayemi, the floor is yours.
Yeah, so good evening from Accra. I know it's good afternoon in Trinidad. I hope you can all hear me clearly.
Yes.
Yeah, so greetings from Accra. Okay. So I'm talking on sickle cell in focus, and I've added a sub-team together in a team. This is the outline of my presentation today. Before I go on, I want to say a big thank you to Society for Inherited and Severe Blood Disorders, Trinidad and Tobago, for inviting me to give this inaugural Dr. Waveney Charles Distinguished Lecture in honor of Dr. Waveney Charles. Unfortunately, I never had the opportunity to meet with her, but reading about her, I've come to realize she was an outstanding hematologist and widely known as the mother of hematology in Trinidad and Tobago. Conflict of interest, like mentioned, the site PI for an ongoing clinical trial, IMR-687, the Ardent study by Imara Incorporated. I'm aware that the audience for this lecture will include a lot of patients with sickle cell disease, their carers and relatives. And as such, I'll try as much as possible to avoid using technical or medical terms as much as possible. So starting off, what is sickle cell disease? It is a group of inherited red blood cell disorders that are of public health significance. In sickle cell disease, unlike the healthy red blood cells that we find, which are around and are able to carry oxygen to different parts of the body, in sickle cell disease, the red blood cells become hard, sticky, and look like a sickle, hence the name sickle cell disease. These red cells break down easily, leading to anemia. Sickle cells can get stuck in small blood vessels, blocking the flow of blood and oxygen supply to the tissues. Then what causes sickle cell disease? This is an inherited disorder, as I said earlier, and it's caused by mutations in the gene that encodes for hemoglobin A. Genes carry information, instructions that are passed from parent to child and determine the traits that we all have, such as our eye color, our blood group, and so on and so forth. So sickle cell disease is inherited in the same way that people get other traits that they have, such as colors of their eyes, I said earlier. The person with sickle cell disease is born with the disease. You cannot catch it from being around the person who has it. I'm aware that there's a lot of stigma surrounding sickle cell disease. So it's not an infectious disease. You cannot get it from being around the person who has sickle cell disease. A person with sickle cell disease may inherit 2 copies of the hemoglobin S gene, one from either parent. When this happens, we say the person has hemoglobin SS disease or sickle cell anemia. It's also possible that a person with sickle cell disease may inherit 1 copy of the hemoglobin S gene from one parent and inherit a different abnormal hemoglobin gene from the other parent. So hemoglobin C or hemoglobin E or D and so on and so forth. These are compound heterozygotes. That's a combination of sickle cell disease gene and another abnormal hemoglobin gene. Again, it is possible for an individual to inherit the sickle cell gene from one parent and the hemoglobin A gene from the other parent. In this case, that person is said to have the sickle cell trait or hemoglobin AS. People who have the sickle cell trait do not have sickle cell disease, but can transfer the hemoglobin S gene to their offspring. Thus, if both parents have either sickle cell disease or sickle cell traits or a combination of these, if they intend to have children, it is best that they discuss their plans with themselves and with a trained health professional in this respect. What are the common types of sickle cell disease? These are not exhaustive anyway, but the first 2, hemoglobin SS, that is sickle cell anemia, or hemoglobin SC disease, make up about 90% of the types of sickle cell disease that we find globally. Hemoglobin SS disease is the most frequent and the most common, makes up about 70% of individuals that have this disease. This is just a pictograph to show you what happens in the blood. So you can see here the sickle red blood cells and to find characteristic of sickle cell disease. And on the other slide, you can see the hemoglobin C crystals, which is found in people that have hemoglobin SC disease. Who is affected by sickle cell disease? This is a disease that affects millions of people worldwide. It is common among people who live in or whose ancestors come from Sub-Saharan Africa, Saudi Arabia, India, and Mediterranean countries such as Turkey, Greece, and Italy. It's estimated that over 300,000 children are born with sickle cell anemia every year. Almost 80% of these children are born in Sub-Saharan Africa, and half are born in 3 countries: Nigeria, Democratic Republic of Congo, and India. In the United States, sickle cell disease affects about 100,000 people, mainly African Americans. Again, this cartograph shows you the atlas. If you're going to draw up the atlas, the countries of the world, and show them according to the population of people with sickle cell disease living in them, you see that Nigeria will be the largest country globe in the world And you can see the Democratic Republic of Congo and India also represented. The distribution of hemoglobin S gene is driven by two main factors: the endemicity of malaria and population movements. There's clear evidence that hemoglobin AS, that's the sickle cell trait, provides protection against severe Plasmodium falciparum malaria. Children with hemoglobin AS are 90% less likely to experience severe malaria compared to those who are hemoglobin AA. This explains the high frequency of the hemoglobin S gene in parts of the world with high prevalence of malaria, such as Sub-Saharan Africa. The other driving factor is population movement. Initially started with the slave trade and now more by economic migration. This has led to the movement of the hemoglobin S gene into North America and Western Europe. And as you can see here, the hemoglobin C gene is largest in West Africa. And as a result, hemoglobin SC has the highest incidence of hemoglobin SC is seen in West Africa. Just a brief talk about our experience from the Ghana Institute of Clinical Genetics in Accra, Ghana. We did a two-year retrospective study, and this shows that in our clinic, our average daily attendance is between 40 to 50, but the attendance differs according to the weather, the times of the year. You see that in January, when the weather is dry and cold, we have a higher level of attendance, and the same thing during the wet season from June, July, and August. The other thing you can see from our chart here is that even though most of our patients are still young, they are less than 40 years, with the use of basic medical care, we are beginning to see more sickle cell disease patients live into their 60s, their 50s, and their 60s and above. So this goes against what used to be known 20, 30 years ago, that sickle cell disease patients in Africa would not see their 18th or 21st birthday. Now we are seeing, even though mortality is still quite high in childhood, we are beginning to see more and more people live into their 50s, 60s, and above. So how do you diagnose sickle cell disease? There are two basic things that you need to do if you want to make a diagnosis of sickle cell disease. The first one is to demonstrate the presence of hemoglobin S. The second thing you can do is to carry out DNA analysis and look out for the mutation at the genetic level. But for everyday laboratory work, we certainly tend to stop at just demonstrating the presence of hemoglobin S. And there are several methods that you can use, some of which are listed here. And the standard practice is that before you can diagnose sickle cell disease by demonstrating the process of hemoglobin S, you should use at least 2 different laboratory methods that are based on 2 different principles. There are several opportunities for the diagnosis of sickle cell disease, from preconception and prenatal, neonatal, and post-neonatal. Preconception testing is designed to identify asymptomatic potential parents who carry the hemoglobin S gene. This generally applies to people who have hemoglobin AS or sickle cell trait, but it also applies to people who have hemoglobin SS or hemoglobin SC disease, who might have very mild diseases, such that they might not have been diagnosed in childhood because their disease is so mild and they are about to have children. Couples who are positive at preconception screening may opt for in vitro fertilization with pre-implantation genetic diagnosis to identify at-risk embryos before embryo transfer occurs. There are a few laboratories and clinics, private clinics in Accra in Ghana, that offer this facility. Prenatal diagnosis is relatively safe, but it is invasive and is offered in early pregnancy, certainly before the end of the first trimester, to couples who are positive at preconception screening. It requires the sampling of fetal DNA, or you need to get fetal DNA samples to carry out prenatal diagnosis, usually. However, there are now non-invasive prenatal diagnostic techniques which can detect fetal DNA in maternal circulation as early as 4 weeks of gestation. Newborn screening for sickle cell disease. This ideally should be performed at birth or soon after birth, before symptoms of sickle cell disease occur. There are 2 types of newborn screening. We have the selected or targeted screening of infants of high-risk parents, and you also have universal screening, where every newborn born in that region or country is screened. Universal screening is more cost-effective. It identifies more newborn babies with sickle cell disease and prevents more deaths. Without newborn screening, initial diagnosis of sickle cell disease in developed countries occur at about 2 years of age. And we know, as you'll see in some of my slides later, that the mortality rate in newborns in low-income countries is very high before the age of 5. So early diagnosis, especially when it is added on to penicillin prophylaxis and family education, has been shown to reduce mortality in the first 5 years of life from less than 25%, to less than 3%, again, in high income, especially in the United States. And newborn screening in the United States has evolved over time from targeted population screening in the 1960s to 2006, when all 50 states and the District of Columbia agreed to carry out universal newborn screening for sickle cell disease. What is the situation in Sub-Saharan Africa? Unfortunately, as I speak to you, no country in Sub-Saharan Africa has implemented a universal newborn screening program for sickle cell disease. A lot of pilot studies and pilot programs have been instituted in several countries, some of which are listed here. It is possible that with the high prevalence of hemoglobin S gene in most parts of Sub-Saharan Africa, cost may be a rate-limiting step, hindering the national implementation of this program. So even though pilot programs have been implemented, they've been shown to be effective and possible, cost has stopped us from rolling them out as a universal program. In addition to this, there's no large-scale preconception screening program in any African country, though some religious organizations require couples to know their hemoglobin S status before marriage. So there have been a lot of reports about newborn screening. This study shows that isoelectric focusing and administration of prophylactic intervention like penicillin is cost-effective in majority of Sub-Saharan African countries. Another pilot study from Liberia, it's another one from Tanzania. So there have been several pilot studies. What about the situation in Ghana? Ghana's new national newborn screening program for sickle cell disease was launched in inverted commas in 2010, following a 15-year pilot study. The program as designed is fantastic. It was designed to be universal. Babies with possible sickle cell disease are referred to a treatment center where a second sample is obtained to confirm the initial screening results. Once this is confirmed, these babies are then enrolled, or are supposed to be enrolled, in a comprehensive care program that includes penicillin and anti-malaria prophylaxis, because malaria is important in our environment, folic acid supplementation, and parental education about the management of sickle cell disease. The Ghana's National Health Insurance Authority is supposed to fund this universal screening program as part of its mandate to provide free healthcare for all Ghanaian children. Unfortunately, this has not taken off. Even experience at the Kumasi Center for Sickle Cell Disease, where the pilot study for sickle cell disease, the pilot study for newborn screening for sickle cell disease was carried out. Irregular funding caused intermittent shortages of laboratory supplies. and limited funding has stalled the national scale-up of the screening program, which currently reaches only 4.2% of the estimated 850,000 neonates that is supposed to be screened in Ghana every year. So we are screening about less than 40,000 neonates a year, when we should be screening about 850,000. Again, another attempt to roll out the newborn screening with the help of Professor Odame at Kolebu Teaching Hospital where I work, where the staff and health personnel have been trained to carry out newborn screening. Again, in March this year, the American Society for Hematology announced the formation of the Consortium on Newborn Screening in Africa, CONSA. This is to provide collaboration between Africans in 7 countries: Ghana, Nigeria, Kenya, Liberia, Tanzania, Uganda, and Zambia, to screen between 10,000 and 16,000 babies a year for the next 5 years. This is going to add on to what we currently have until we become truly universal. What about postnatal testing? There are several people who are already born, they are already alive, didn't have the opportunity of being screened when they were neonates. What happens to them? Especially those people who have hemoglobin A, S, and like I said, other forms of sickle cell disease that have been mild and might not have been diagnosed because of the mild form of the disease that they have. While I was the director of the Guardianship of Clinical Genetics, we instituted a program where we went to senior high schools to screen them for sickle cell disease. This is done after getting parental consent, and we get assent from the students. So the picture here shows one of the senior high schools in Accra, where we went to address them. So the picture on the left, my left, shows the students in the assembly hall, where a medical staff talks to them about sickle cell disease and the need for them to be screened. We did this because we wanted to screen at a point in time where romantic relationships have not taken hold. Most times, by the time people get into their early 20s and mid-20s, when you even tell them that, oh, you are AS and you shouldn't have a partner with AS, then they are not willing to listen to you anymore. But when you get them at this age, we screen them, we give them a card where their hemoglobin status is written, their blood group is written, and they can keep that card as reference for future purposes. This is one example of postnatal screening. Severity of sickle cell disease, like I've mentioned earlier, varies. There are people who have mild disease and other people who have severe disease. Even among people who have the hemoglobin SS, which is supposed to be the severest form of the disease, you also have people who have mild forms of the disease and people who have more severe forms of the disease. And it's been shown that genetic modifiers like hemoglobin F concentration and co-inheritance of alpha thalassemia plays a role, as do the haplotype. It's been shown and it's known that the Arab-India haplotype has a milder phenotype, that the severity is milder than the 4 African haplotypes, the Guinea, Bantu, Cameroon, and Senegal haplotypes. Then, apart from genetic modifiers, environmental factors like the home environment, socioeconomic status, nutrition, and access to care also influences the severity of the disease. What are these health problems associated with sickle cell disease? There are 2 main things: the pain episode, which is known as the hallmark of sickle cell disease, and anemia. Anemia is common in sickle cell disease because the red blood cells live for about 20 to 30 days, while the normal red blood cell is supposed to live for about 120 days. So they don't have enough red cells left in the system to transport oxygen. I made a mention to it earlier that data from African studies indicate that childhood sickle cell anemia mortality before 5 years in parts of Africa is between 50 to 90%, and most of our children die from infections. The pain crisis, vaso-occlusive crisis. What happens? How does it occur? The sickle red blood cells can lead to recurrent vaso-occlusive pain episodes, which is the hallmark of sickle cell disease. The hemoglobin S in the red cell polymerizes, that is, they combine together under low oxygen tension. These red blood cells then undergo abnormal shape change to become, to show the characteristic sickle shape. They become inflexible and the membrane of the red blood cell breaks down easily. Once the membrane is destroyed, the red blood cell releases hemoglobin into the system, and the body tries as much as possible to prevent hemoglobin from going about free in the body. Apart from that, even when the red blood cell, the sickle red blood cell is not broken down, the deformed red blood cells are sticky. They tend to adhere to themselves, to the inner lining of the blood vessels, the endothelium, and also the other parts, cellular components of the blood, like the neutrophils and the platelets. All of these makes it impossible or difficult for blood to flow through small blood vessels, further depriving the body of oxygen. The chart here shows you what happens when you have oxygen, normal, beautiful looking red cells, and when it becomes deoxygenated, the red cells assume this sickle shape. The sickle red blood cells, because of activation of the endothelium and other contents in the blood, stick together and occlude the small blood vessels. Don't forget, I talked about release of free hemoglobin. What happens? Free hemoglobin consumes nitric oxide. Nitric oxide is a compound in the body that helps to helps to allow the blood vessels to relax, makes the blood vessels relax, vasodilatation, they dilate. This reduces the blood pressure and allows for smooth flow of blood. However, when you have free hemoglobin in the system, the free hemoglobin actively consumes nitric oxide, leading to endothelial dysfunction. So the blood vessel becomes constricted, the lumen becomes narrower, and makes it easier for the sticky sickle cell to get stuck and impairing blood flow. This leads to inflammation and damage, ischemia, to end organs and tissue. So hemolysis plays a major role in some sickle cell complications. This acute pain usually affects the extremities, that's the limbs, upper and lower limbs, the chest, and the back, and often the most common cause of hospitalization in people living with sickle cell disease. However, a lot of people have just mild to moderate pain, and sometimes this can be managed at home with oral analgesic, rest, and adequate hydration. However, if this is ineffective, then the patient should be taken to daycare, a day unit, for treatment. The treatment is guided by the severity of the pain using self-reported severity scales. We use the pain ladder to manage, so mild pain, moderate pain, and severe pain, depending on where the patient falls into when they are seen at the health facility. Although intensive analgesia with opioids is effective in medical management of acute pain in sickle cell disease, in some countries, opioids are either unavailable because of cost or are not prescribed due to stigma. Acute chest syndrome is another important health problem. It's the second most frequent reason for hospitalization and a leading cause of death, often associated with an acute pain event. So somebody has acute pain event, if you don't treat fast enough, they can progress to develop acute chest syndrome. The severity of acute chest syndrome increases with age, and mortality also increases with age. So we have to have a high index of suspicion with early imaging, chest X-ray, oxygen monitoring, and incentive spirometry of sickle cell disease patients with pulmonary symptoms. Hospitalization, prescription of broad spectrum antibiotics, oxygen supplementation, and red cell transfusion are often needed to treat this. Stroke, another fearful complication. children with sickle cell anemia have a 300-fold higher risk of stroke compared to those that do not have sickle cell anemia. And one estimate shows that by 45 years, 1 in 4 adults with sickle cell anemia will have had a stroke if you don't do anything. Ischemic stroke is commoner in children, while hemorrhagic stroke tends to be commoner as age increases. Anemia, leukocytosis, hypertension, silent infarction, acute chest syndrome, and risk factors for ischemic stroke in sickle cell disease. So you see that pain is a risk factor for acute chest syndrome, because if you don't take care of pain early enough, it can lead to acute chest syndrome. And acute chest syndrome is a risk factor for stroke in children with sickle cell anemia. We need to have prompt evaluation with imaging. Rapid exchange transfusion is one of the standard treatment, and chronic transfusion is used to prevent secondary stroke. Now, sickle cell disease and pregnancy is something we have been working on for the past 6 to 7 years. There's an unacceptably high morbidity and mortality rate seen in this group of women. So in 2013, a multidisciplinary team made up of anesthetists, hematologists, and so on and so forth was established to run a clinic dedicated to the care of pregnant women with sickle cell disease at Kolebu Teaching Hospital in Accra, Ghana. A systematic review and meta-analysis carried out by this team to evaluate pregnancy outcomes was published in 2015 in the British Journal of Obstetrics and Gynecology. Our multidisciplinary team established that sickle cell disease was associated with intrauterine growth restriction, perinatal mortality, and low birth weight. Sickle cell disease was also associated with an increased risk of preeclampsia, eclampsia, and maternal mortality. So we concluded that pregnancy in women with sickle cell disease is associated with an increased risk of adverse perinatal and maternal outcome in both low and high income countries. Then we went further to analyze the results from our multidisciplinary care. Here we used a prospective cohort design. We tested the hypothesis that implementing a multidisciplinary care team for pregnant women with sickle cell disease in a low resource setting will result in similar maternal and perinatal mortality rates compared to women without sickle cell disease. In all, we enrolled 149 women with sickle cell disease and 117 women without sickle cell disease, and followed them up to 6 weeks postpartum, post-delivery. Maternal and perinatal mortality rates were our primary outcomes. In this study, we were able to demonstrate that using a multidisciplinary care, there is obviously no difference in maternal mortality rate or perinatal mortality rate in people with and without sickle cell disease. So multidisciplinary care of pregnant women with sickle cell disease may reduce maternal and perinatal mortality rates to levels comparable to that of pregnant women without sickle cell disease in low resource settings. Plans are currently being made to roll out this multidisciplinary team care to other hospitals in Accra and other parts of Ghana. Leg ulcers are another chronic complication. Individuals with sickle cell disease may develop recurrent painful leg ulcers. The prevalence of chronic leg ulcers from studies that have been done varies geographically, being more common in Jamaica and Ghana than in North America and Saudi Arabia, where it is virtually non-existent. Chronic leg ulcers and sickle cell anemia rarely occurs before the age of 10. The ulcers run an indolent course. They heal slower than venous ulcers, and over 90% of healed sickle cell chronic leg ulcers will recur in less than 1 year. The increased disability, absence from work or school, and high utilization of healthcare resources severely affect the quality of life of individuals with sickle cell anemia and chronic leg ulcers. What causes sickle cell leg ulcers? There's been a lot of theory. I've listed quite a number of them here. I won't go over them individually. But just note that there are certain conditions that are associated with chronic leg ulcers, which you should check for if you find an individual with sickle cell disease and chronic leg ulcer. This is severe anemia, like I said earlier, acute chest syndrome, pulmonary hypertension, priapism, and stroke. We should also note that it is not everybody with sickle cell disease is an individual. They might have other medical conditions apart from sickle cell disease. So the fact that somebody has sickle cell disease and has a leg ulcer does not mean you should assume automatically that the leg ulcer is the cause of that sickle cell disease is the cause of the leg ulcer. We should also find out and exclude the presence of varicose veins and diabetes, which might be more easily treatable as causes of leg ulcer. And the ulcer should be staged. There are certain investigations that need to be done before you start treating your patient with sickle cell associated leg ulcer. Management, again, a multidisciplinary team. You need hematologists, a nurse trained in dressing ulcers, general surgeon, or a plastic surgeon, dietitian, and social worker. How are they managed? For the small ulcers, this can be treated at home. Patients are advised to rest affected limb and elevate it as much as possible. This reduces edema and venous pressure and helps the ulcer to heal. We teach them to dress the ulcers daily, ensure adequate intake of calories, though economic undertones might not make this possible. Folic acid and vitamins, folic acid, vitamin C, and zinc supplements are prescribed. For large ulcers, we need to remove the dead and necrotic tissue. Usually we dress alternate days because these ulcers can sometimes be very painful. Leg compression, if available and there's somebody trained to do it. Antibiotics are only indicated when there's evidence of infection. We do not treat normal skin flora. Again, nutrition is important, tetanus prophylaxis, and in cases where the ulcers are, the patient is being prepared for skin grafting, we might give blood transfusion to maintain the hemoglobin at 10 grams per DL and also reduce the concentration of hemoglobin S to less than 30%. Other health problems associated with sickle cell disease include hand and foot syndrome, which occurs in children from about 6 months to 2 years, where there's swelling of the hand and the feet of the child, of the infant. Infection, I'll talk a little bit more about that in a bit. Eye disease, asymptomatic proliferative retinopathy, is 3 to 4 times commoner in hemoglobin SC patients than hemoglobin SS. And if untreated, it results in loss of sight. So even though people tend to say, oh, hemoglobin SC is milder than hemoglobin SS, there are certain complications that are commoner in people who have hemoglobin SC, and we need to screen them. So at our clinic, we encourage our patients to have their eyes checked every year if they have hemoglobin SC, and every other year if they have hemoglobin SS. So overview of management. How do you manage? Again, a multidisciplinary team, pediatricians, physicians, hematologists, nurses, health educators, genetic counselors, social workers, and psychologists. You might not have all of this in one clinic, but you make do with the best that you have. You counsel and educate the parents, if you are talking about a child, or the patient, if it's an adult, about sickle cell disease. Risk factors that precipitate, you tell them about the risk factors that precipitate sickle cell crisis and how to prevent or slow progression of complications of the disease. We encourage them to take adequate calories and fluids and prevention of malaria through the use of insecticide-treated mosquito nets and also folic acid supplementation. Unfortunately, most times people focus on pain when they talk about sickle cell disease, and they forget about preventive management. Preventive strategies have changed the long-term outcome in sickle cell disease and have been responsible for improvement in survival globally. Prophylactic penicillin for children less than 5 years has been shown to decrease incidence of pneumococcal bacteremia, as has vaccination against pneumococcal infection and other vaccines. Although this comes with a possibility of resistance to penicillin. So we carried out a study at our institute a few years back, where we did a cross-sectional study of 400 people, 202 children and 200 adults. The prevalence of strep pneumoniae carriage among children was about 39%, almost 40%, while in adults it was 10%. We isolated 26 pneumococcal serotypes. But the interesting thing here is that among the children, the serotype coverage of the 13-valent pneumococcal conjugate vaccine currently in use in Ghana was just 32%, while the prevalence of penicillin resistance was 37%, which means the pneumococcal strep pneumoniae was still about 60% or more were still sensitive to penicillin. So we continue to prescribe it to our children. Stroke prevention. Again, stroke is a major cause of mortality and morbidity in children and also in adults. Transcranial Doppler screening can identify children at high risk for stroke. And these children are offered chronic monthly transfusion, which has been shown to reduce the rate of strokes from about 11% to 1%. Again, this is in high-income countries. Chronic transfusion therapy for primary stroke prevention is not available in most low-income countries. However, hydroxyurea has been shown to also decrease TCD vascular velocity, and has been shown that you can use hydroxyurea for children who have been on chronic transfusion for more than a year. Again, the stroke prevention study in Nigeria, SPIN, provided evidence that TCD screening followed by a fixed dose hydroxyurea is feasible and has the potential to prevent strokes in low resource settings. Pulmonary complications can also be prevented if we monitor our patients closely, because asthma in sickle cell disease has been shown to be an independent predictor of mortality. So if you have a child with sickle cell disease who also has asthma, that child should be treated and followed up closely. We should also try as much as possible, if available, to measure the tricuspid regurgitant jet velocity, the TRV. Again, it's an independent predictor of mortality. Proteinuria is strongly associated with progressive disease in people with sickle cell disease, and about 30% of patients with sickle cell anemia will develop chronic kidney disease. If you follow up your patients, monitor them, you find that they have proteinuria, you're advised, if there's no other contraindication, to prescribe angiotensin-converting enzyme inhibitors, which could lower the risk of progression of the kidney disease. Until a few years ago, there were only 3 treatment modalities to mitigate the acute and chronic complications of sickle cell disease. These were hydroxyurea, red blood cell transfusion, and hematopoietic stem cell transplant. Hydroxyurea induces hemoglobin F and tends to prevent sickling. It also causes reversible myelosuppression, decreasing the white blood cell count, the platelets, and the reticulocytes. Remember that these are cells in the blood which, along with the lining of the endothelium, play a role in sickling and in vaso-occlusion. Hydroxyurea also helps to improve the nitric oxide donor bioavailability, which is reduced. Remember I said the nitric oxide level is reduced by free hemoglobin. So we've been using hydroxyurea since 2015 at our clinic, and towards the end of 2019, Novartis partnered with the government of Ghana to roll out free hydroxyurea for all patients diagnosed with sickle cell anemia in Ghana. Currently, we have about 400 patients at our clinics on hydroxyurea. Hydroxyurea is still underutilized because of poor healthcare infrastructure. Before you can use hydroxyurea, you need to be sure of available laboratory support, and even in some cases, blood transfusion support if the hemoglobin drops so low that you need to transfuse the patient. Some individuals with sickle cell disease are opposed to taking hydroxyurea or are intolerant to the medication. There is still a wrong perception about the risk of carcinogenicity in sickle cell disease patients on hydroxyurea, which has never been proven, teratogenicity, as well as the effect of hydroxyurea on fertility. However, in spite of this wrong perception, the use of hydroxyurea in treatment of sickle cell disease is gradually increasing globally. It is even effective in children as young as 9 months, as has been shown by the Baby Hug clinical trial. So, despite the effective nature of hydroxyurea, we have some patients who have hydroxyurea but have inadequate clinical response despite taking the drugs regularly. This suggests that there are other pathways responsible for vaso-occlusive crisis not fully mitigated with hydroxyurea. So hydroxyurea has been shown to reduce the frequency of vaso-occlusive crisis, acute chest syndrome, requirement for blood transfusion, and hospitalization in children and adults with sickle cell disease. And fixed low-dose hydroxyurea has also been shown to be effective, and it has lower toxicity. And this may be the way to go in low-income countries. Hydroxyurea has been shown to decrease risk of stroke and chronic kidney disease and may reduce mortality in sickle cell disease. So these are some of real-world experience from Africa. It's from Malawi, where it was shown that within 6 months of starting hydroxyurea in children with sickle cell disease, they were able to get some response. Chronic transfusion, this is again, like I said earlier, used primarily to reduce the risk of stroke in people who are high risk, especially children, where you have the high transcranial Doppler velocity measured in them. However, transfusion comes with risk of alloimmunization, transfusion-transmitted infections, and iron overload. Hematopoietic stem cell transplant is said to be curative, and it is curative in severe sickle cell disease. Outcomes have improved over the last few years with introduction of milder conditioning regimens. It is best in people who have matched sibling donors, but most people don't have a HLA matched related donor. Recently, there have been increasing use of haploidentical donors and matched unrelated donors. But cost, along with the fear of complications like graft-versus-host disease and infertility, have reduced its application. Having said that, 6 countries in Africa currently have the capacity to carry out hematopoietic stem cell transplant. The first was done in South Africa in 1976. The first in Nigeria was done in 2011. And in 2018, we had the first hematopoietic stem cell transplant in Ghana. Unfortunately, the stem cell unit in Ghana, after transplanting about 8 patients, has ceased to operate. So instead of 7, we still have 6 countries in Africa with the ability to carry out stem cell transplant, even though there's a unit fully equipped in Ghana. And this is a picture of the unit in Ghana. In the middle there, you find the private stem cell facility in Nigeria. It's another picture from the unit in Ghana while it was functional. I'll just talk about, you remember that I showed you a cartograph that showed that Nigeria has the highest burden of sickle cell disease worldwide. This is, as of 2013, what is available for management of sickle cell disease in Nigeria. 18 health institutions, and these are tertiary health institutions in Nigeria, were surveyed. You see that yes. So you see that penicillin prophylaxis is used mainly in the pediatric unit, but hydroxyurea was only available in 8 out of 18 units or 18 institutions, health institutions, tertiary health institutions in Nigeria. And when you look at facilities available, not all of them have electronic cell counters. So you see the reason why they might not be able to do hydroxyurea. HPLC is only available in 3. Newborn screening is not, was as of 2013, was not available in any facility in Nigeria, and so on and so forth. Novel drugs. So I'm rounding up now. Apart from hydroxyurea, which has been used for several decades now, some newer drugs like crizanlizumab, L-glutamine, and voxelotor have recently been approved for treatment of sickle cell disease. But if you look at so all of them, apart from crizanlizumab, are given orally. Crizanlizumab is given intravenously, and they all have different mechanism of action. But hydroxyurea still has one of the largest effect sizes when you treat, so about 44% decrease in VOC per year. Okay, so hydroxyurea for us in low-income countries, for the next couple of years, hydroxyurea will remain the drug of choice because of cost and availability. The future. What does the future hold for sickle cell disease? A person with sickle cell disease can live a long and high-quality life. To do this, they are encouraged to get regular checkups with their doctor and follow treatments prescribed. They are able to prevent infection by penicillin prophylaxis in children and up-to-date vaccination. Wash hands regularly. If there's anything that COVID-19 has taught us, is that if you wash your hands frequently and you don't put your hands in your mouth or unclean hands in your mouth, your nose, and your eyes, you can actually prevent a lot of infections. Practice healthy habits like adequate hydration and taking balanced diets. Unfortunately, improvement in lifespan in terms of sickle cell disease tends to be associated with increased risk of organ damage. In the future, we want more sickle cell disease research from Africa, led by Africans. This chart from Williams in 2016 shows that as at 2014, there are about 1,000 studies globally, and less than 100 originated or were led by Africans, even though there has been a steady rise, but the rise is not fast enough. I talked about organ damage previously. NIH has founded the Sickle Cell Genomic Network of Africa. This is a network of African scientists and international collaborators, which is studying approximately 7,000 children and adults with sickle cell disease in Africa to identify genetic markers associated with development of organ damage, with a special emphasis on the body's defense against molecules released from damaged red blood cells that cause tissue injury, specifically hemolysis. The long-term goal is to develop strategies to predict, prevent, and treat organ damage in sickle cell disease. This network is currently active in 3 countries in Africa: Ghana, Nigeria, and Tanzania. There are 3 interrelated projects. Project 1 is looking at genetic determinants of hemolysis modifying defense in sickle cell disease, especially haptoglobin, hemopexin, alpha-1 microglobulin, hemoxygenase 1, and ferritin. Project 2 addresses the genomics of severe malaria complications in sickle cell disease, while Project 3 looks at the genomics of cardiovascular phenotypes in sickle cell disease. The future, again, together in a team, multidisciplinary team care for sickle cell disease will become the standard. Universal newborn screening will become universally available. Wider availability of hydroxyurea in Sub-Saharan Africa and other low-income regions, probably at a fixed low dose. Wider availability of novel agents and gene therapy. Thank you for your time and for inviting me. Thank you very much.
Thank you, Dr. Olayemi. So at this point, we will take a short break for 10 minutes. Please don't go too far, but take note of your questions and we will return for the panel discussion. Each panelist will be allowed to speak, comment on Dr. Olayemi's presentation or speak about any aspect of sickle cell disease of their choice for about 5 minutes. Then we'll allow Dr. Olayemi to respond, and then we will have a question and answer segment. So at this point, feel free to take a stretch, go for a drink or a snack, and we will start promptly in 10 minutes. It is now 4:03. So for this section of the panel discussion, we will have Ms. Karen Eddy moderating. And we will start with Professor Odame. Yes?
Right. Thank you very much. So Professor Olayemi gave a very comprehensive talk about sickle cell disease and laced it with specific experiences from Ghana and Sub-Saharan Africa. So that was a very good overview. I have just a few comments. So if you look at Sub-Saharan Africa, the main improvement that has come to benefit sickle cell children generally is because of primary immunization with Prevnar. Because as he said, even in Ghana, where newborn screening has been going on for decades, only about 5% of the children are detected at birth. So the majority are not detected. But fortunately, as part of primary immunization through the Gavi program, all these children receive immunization against pneumococcal infection. And I think that has been one major progress that we should recognize. It's not because of any specific sickle cell related strategy. Secondly, there's been a very remarkable progress with reducing malaria-related mortality by the use of bed nets, rapid treatment of malaria. And I think all over Sub-Saharan Africa, we know that malaria-related mortality has almost halved. And that is thanks to initiatives like the Gates Foundation and the President's initiative, the PEPFAR initiative that has benefited these countries. So the progress we've made there have been progress made from general public health measures, which has benefited many of the children, because we are still lagging behind early detection. And I believe if we can expand newborn screening or even diagnosis at the point of care or receiving immunization. And this is where the point of care tools that are emerging will be very significant, because they could be integrated into immunization programs so that in those settings, children who have not been diagnosed at birth or near birth time can be picked up and will benefit from extra addition of penicillin to the Prevnar vaccination. The other point I wanted to make was about survival. If you notice from the very informative chart, bar graphs he showed with regards to survival and mortality in his clinic, we do know from newborn screening in Ghana that 45% of children with sickle cell disease in Ghana are of the SC type. But as they get older, you will notice from the bar graph that the SC overtakes the SS, which suggests that people with SS have a shorter lifespan. And as you look at the pool, as they get older, in fact, above 60 and onwards, the majority, nearly 90% of them were SC patients. And so we need more solutions for the SS patients. And as Prof. Olayemi showed, the uptake of hydroxyurea among the adults, whilst it is increasing, is still far, far below what it should be. And this should be the focus of Sub-Saharan Africa, where a lot of SS patients who need hydroxyurea therapy earlier in their lives to be able to make a remarkable change in the course of the disease. If we don't do that, we are going to see a wider disparity between those with SC and SS. So those are some of my comments. I think from where I sit, if the whole of Africa united under the auspices of the African Union and decide that hydroxyurea is an essential drug that needs to be available to low middle income countries, Africa could produce hydroxyurea at a big fraction of the cost that it is now. And it will be so cheap that it will be affordable taking on national health insurance coverage to make sure that every patient with sickle cell disease who needs hydroxyurea will have access to it. But I think finally, the number one barrier to hydroxyurea use today in Sub-Saharan Africa is probably healthcare professionals themselves. Many healthcare professionals are not aware of the evidence, or even if they are aware of the evidence, are hesitant about it because they lack training and expertise in it. They are nervous about using hydroxyurea, and therefore they don't provide the strong encouragement to patients and offer it to them. So Professor Olayemi, our work is cut out for us. We need to train more and more health professionals to be comfortable with using hydroxyurea. There have been over 30 years of research with hydroxyurea. It's now been researched in children and adults in Africa, and we know that it is safe. And in fact, those on hydroxyurea have less clinical events than those who do not take it. So we need more training. We need more health professionals to be recommending it. And that is what is going to persuade patients and their families that indeed hydroxyurea is both efficacious, is safe, and it makes a lot of difference in the outcomes. Those are my comments. Many thanks.
Okay, next we have Dr. Aznani.
Hi, thanks so much. Thank you, Dr. Odame, and special thank you, Dr. Olayemi. It was really a pleasure listening to you. Such a wonderful, comprehensive talk, not just on sickle cell disease, but I learned a whole lot firsthand on what's happening in Africa, especially Ghana. You know, we keep hearing of the excellent work that's coming out of Africa, because really and truly, as we all know, that's where the disease has the highest prevalence. And we in the Caribbean kind of sit in the middle of US, UK, and what's happening with Africa in more than one ways, you know, socially, culturally, and other resource constraints and not constraints. So it was really great listening to you and how much you all have been able to achieve. And I was really, really happy to see, and I wish we could get something like that in the Caribbean, with your comment on Novartis now enabling every patient with sickle cell disease, is it in Nigeria or in Africa, to avail hydroxyurea. And when you do get to answering, I wonder, are they also doing the whole hydroxyurea coverage, including monitoring, etc., or just the drug itself? So it was really amazing talk. I really enjoyed it. Thank you so very much. For my comments, you know, so much has been said today, and you know, it's been an extensive, wonderful overview. So I was thinking what I should state. Dr. Odame did touch on one thing of what I was thinking. So I'm going to speak to just two things quickly. One is clinical and one is a little bit social and psychological, a little bit psychosocial. One is hydroxyurea. In the Caribbean, despite so much evidence of the benefits, and even in Jamaica, the National Health Fund, which is a government scheme for enabling very subsidized medications to its population, as well as the Sickle Cell Unit and the Support Foundation, have really worked together with the Ministry of Health, whereas for the last 3 months, every prescription that is written, not only in the healthcare facility, because there's universal health care in Jamaica, but the Sickle Cell Unit never quite came under the umbrella of the ministry. Dr. Odame, you know that. But now for the last 2 or 3 months, every prescription that's written by us at the Sickle Cell Unit, the patients can take that and avail it to the free delivery of medications. So we are hoping access to hydroxyurea is really not a problem. And hydroxyurea is really not a very expensive drug. Yet, even in a place like Jamaica, where you would think there's a huge amount of spotlight on sickle cell disease, the uptake of hydroxyurea is less than 1%. I almost feel guilty as a clinician that so few of our patients, whereas everybody who comes to you with diabetes or hypertension or other NCDs, we quickly move on to medications. And I really feel guilty that so many of our sickle cell patients are not being put on it. So that is my one thing. And I don't think the story is much different for the rest of the Caribbean. And I think that's something through CAREST, which is a Caribbean network of researchers in sickle cell disease and thalassemias, which you all are familiar with. We need to work on that because, you know, I call hydroxyurea game changer, and I will not give up. I tell my patients we cannot give up on hydroxyurea if after a month or two we are not feeling better. We really need to just try it. It is a game changer for the lives of persons, children's growth, babies' growth, cognitive development, and then of course, reducing complications. So I really think in the Caribbean, how we can work together to improve hydroxyurea utilization from health systems point of view, healthcare providers point of view. Dr. Odame, your point is spot on. We know that, you know, with healthcare professionals training, which is needed, and we have been working actively on that for the last 2 or 3 years as well. But we need to get this uptake going really much more than where it is, less than 1% in my unit, which is a specialized center for sickle cell disease. The second thing I want to speak on, which comes to me, which confronts me more and more, even though my work at being a family doctor has always concentrated and focused a lot on the other issues that are affecting patients, both determinants and outcomes, which are psychological and socially driven. And you know, even in our chat that we had yesterday, Kira, Renee, and the team, you know, on reproductive issues, and we spoke to adolescents and children, is reducing stigma. You know, and I know Dr. Olayemi didn't have much time, you know, to speak on the psychosocial, and I have no doubt that it is similar situations that you have there. I am convinced, listening to patients, that if we do not address from childhood the stigma, which can be driven by, you know, lack of information, obviously, right? Because if people understood, if families understood, if communities understood, including churches and schools, etc., that there ought to be no stigma attached to a disorder that is genetic in nature. And then, of course, management of pain, where stigma really, really affects every aspect of pain management. The stigma that the patient faces, not only at the healthcare facility, but even within families, their own family, within their growing period at school, you know, as a teenager, stepping out in the workplace, not being able to declare that you have sickle cell disease for the fear that they will not get a job because they are taken as drug addicts and 1, 2, 3 for the, we really, and you know, in my country, in Jamaica, Renee and Kieran, the Sickle Cell Support Foundation of Jamaica, which is a peer support group, has been the major advocates. They have had successes that the Sickle Cell Unit has not enjoyed in getting you know, governments and so on to understand. They really push for newborn screening. They really push for the drug to come on National Health Fund. We have been their partners, but they have had loud voices. And I think we need to challenge ourselves in the next 5 years. What can we really do together to really actively hit the stigma? Because we spoke about self-esteem in the children and all of that. You know, I do believe that patients' lives are going to be so much richer and much improved quality of life if people around them understand the disease. You know, I plead to whichever healthcare professionals when I speak to them that let us not add another cross to people's lives. They're already born with something that they have no control over. Let's not be an added burden on them. So Renee, and team Kieran, can we challenge ourselves and see how we can really move towards reducing the stigma in a very active way? I'll stop there for now. Thank you so much.
Thank you, Dr. Aznani. That is something that hits home for me a lot. And we are definitely going to be trying to collaborate with yourself and others to give us that push forward to getting that mental health issues and the stigma of having inherited blood disorder. But before we go on, Dr. Charles, can you allow Dr. Olayemi to respond to any of the panelists, please?
Oh, sorry, I wasn't raising my hand. I was scratching my head.
Okay.
Proceed. Do proceed, doctor.
Okay, so thank you very much for your kind words and comments and questions. So Novartis, I think Professor Odame might know about this. I think we were involved in the negotiation. So Novartis came on board. I think the plan is to move hydroxyurea onto the National Health Insurance Scheme. Ghana has a relatively good National Health Insurance Scheme. It takes care of the basics, so basic infections and other things are covered, and some labs. And for hydroxyurea, you really don't need sophisticated labs. Just an automated analyzer will do. So I think the plan is to move hydroxyurea supply onto the National Health Insurance Scheme. So from the feedback I'm getting, Professor Odame can correct me, the Novartis scheme will end this year, and the Ghana government is supposed to move the hydroxyurea supply onto the National Health Insurance Scheme. So it's supposed to be like a stopgap thing to get the whole hydroxyurea started. Then stigma. Yes, I mean, this is something we all deal with. My clinic is almost directly opposite a senior high school in Ghana, one of the popular senior high schools, a girls' school in Accra. And I remember a few years back, a little girl comes in. I was walking to the clinic, and this little girl was by the passageway crying. And initially, I thought she was in crisis. So I asked the nurse that, why didn't you put her on the bed? Why you need? I said, oh, she doesn't have crisis. They don't know why she's crying. And I took her to the consulting room, calmed her down, and she was in her school uniform. And the reason why she was crying was that her classmates in school were always teasing her that she was going to die when she turned 18 because she had sickle cell disease. And that day, she just couldn't take it anymore and broke down and was crying. Luckily for me, that same day, I had one of my clients who was an accountant who was coming to see me in clinic. She also had sickle cell disease, and she was in her 50s. So I just called the lady in, and I left her with a little girl in my consulting room, and I gave them some 10 minutes. And this lady spoke to her and told her, oh, me, I'm an accountant, I'm successful, I went to the university, I'm married, I have kids and all that. And you could see the change in the face of the little girl, because now she has somebody to look up to. Now she has something to target, to put as a target, knowing that she can take care of herself. And what her classmates were telling her that she would die at 18 was just rubbish, to put it lightly. So stigma is there, but we need to come together and find solutions to address it. It happens, I have clients who will not tell their employers that they have sickle cell disease. So anytime they have to come to clinic, they make up stories. And I keep telling them, how many stories can you make up before somebody catches on to you that there's something wrong somewhere? So it's quite a big deal. Luckily for us at our institute, our clinic, we've been able to get clinical psychologists in-house, and they've played a large role in helping us address some of this issue. But stigma is, yes, it's a big problem also in Ghana. Thank you.
Thank you, Doctor.
If I could just comment, based on that story Professor Olayemi gave, I remember in secondary school, a classmate also told me, I read in a book that you'd only live up to age 20. People with sickle cell only live to age 20. And I immediately disregarded that, because through the support group and the knowledge I had from being in the support group, I knew that that was rubbish. And so, I think that is important for patients coping, to have that knowledge. Okay, that's it. And I do accept Dr. Aznani's challenge about really addressing that issue of stigma.
Thank you, Renee. Can we now go on to Dr. Kenneth Charles?
Yes, thank you. Thank you for inviting me as a panelist. And may I again commend the organizers. And I'm assuming it was all these young folks who looking at me and heckling me all afternoon. Yes, I want to commend Dr. Olayemi, who I had the pleasure of meeting in 2 or 3 conferences elsewhere, because we're both part of a special interest group for global hematology, which really does, I think what is needed, it unifies a cause and brings it to international attention. Having said that, I trained in hematology in the UK at a time when stem cell transplantation and all these molecular techniques and so on were high flying and very exciting, and stem cell transplantation, everybody wanted to be a transplanter. And then while there, I noted that though the community was well supplied for blood, simple blood for transfusion, there was an abject deficiency of blood donation in all the communities that arose from the previous British Empire. And all of them practice what we call replacement donation. And really it is kept at a very low profile in the literature, because some of the authors to which Dr. Olayemi alluded, when he said a lot of the research about Africa comes not out of Africa, but elsewhere, a lot of the authors come from countries who take that service for granted. They have established blood transfusion services. So they could now build further and speak about other developments. But the core of our problem, if you look at the map of the world, is that all the places that are with all the sickle cell disease and thalassemia and present company all included, you all come from countries, or parents come from countries that are similarly afflicted. We have very bad blood donation services. So that even if we have let's say prenatal screening, then the possibility a child could come in with acute splenic sequestration and succumb because of the unavailability of blood. And it's a very, very big problem, which I think is not given enough importance in the international literature. And that's because it's not a problem in the developed countries, and therefore it is not addressed. But we as a group have to keep publicizing it from here and doing what we can to improve our transfusion services. And it's a big deal. And like I was saying, when I came back, I had aspirations to do other very high-tech things, but I came back and realized that it's a deep social problem that affects every stratum of society, every medical field. And if every field is stranded, then this field is deprived. Because if there's blood shortage to do chronic transfusion where it's indicated, and the supply goes to surgical patients, yes, then a deficit arises about which we must start addressing internationally and do something about. And a lot has been done in Ghana, I know about that, but we must keep that in mind. And as part of your advocacy, young ones, which I agree with it as well, we must not just advocate, we have to derive evidence as well, and statistics and publish things about your experiences. Let the world know, and sub-stories don't work. Very objectively that so many patients came in, so many waited for so many hours. Yes? And then make a case. I think sickle cell disease is a non-communicable disease. it's not a lifestyle disease that you get because you were excessive in some ways. It falls upon one. And I think it should be addressed that way. I think we should be lobbying for that. And really, and as part of it, to have hydroxyurea on a CDAP, because it then becomes a drug for non-communicable disease. But you have a lot to do by way of public information, and you must embrace the portals that are available for doing that, and do it globally. And keep in mind that I am not suggesting this is the case, but the whole association and what that for which it stands is best served by perhaps strategically aligning it to things that give them high prominence. I can tell you non-communicable disorders is one. I can tell you, this is inside information, that restructuring of the blood transfusion service is another one that's a high priority. So if somebody gets involved in that and incidentally, yes, I think sometimes it gets some unexpected prominence and attention. And the last thing about hydroxyurea, I'm a bit advocate for it, and I must let you know that I was a doubting Thomas when it was first brought out. As a matter of fact, I objected to the suggestion that this anti-cancer drug be experimented with on people from the developing world. And then 20 years later, I've seen the benefits. I'm here as an advocate. And I want us to take it further and demonstrate the efficacy in using it. And we don't have to say in a low resource setting, it's just using it. It's beneficial. And some of the myths that, well, they become myths, we have to call them that, about it affecting pregnancy and so on. We have to advocate to show that it is, if it was used safely, inadvertently in pregnancy, like we've used it twice or 3 times inadvertently, and then deliberately, without ill effects. If we start publicizing and publishing that information, it'll eventually get out there and we become even more of a voice. I'll not take up any more of your time. Thank you very much for having me.
Thank you very much, Dr. Charles. We are going to take up your suggestions. We are also going to be taking up trying to get you involved with us going forward in some of the things that we would like to do nationally, internationally, so we can bring more awareness to sickle cell disease and inherited blood diseases. We are also looking at ways to change the mindset, if that's the right word I'm using, of our population, of becoming voluntary blood donors for all cases, not only inherited blood disorders, because I mean, we use a lot, but everybody needs blood at some point in time for something. So we will be taking you up on any offers or any sort of stuff we're going to be trying to do to bring more awareness to all these things and get our mindset to, let's say, a first world status whereby blood donation becomes something very voluntary and very natural for people to come and do. Thank you to the panelists. I have a few questions that I would love to ask. Or
Aaron, just before you proceed, I just want to respond to some of the things Dr. Charles said. I want to use myself as an example, right? In 1999, I suffered a stroke, right? And immediately following that, I had acute chest syndrome for the first time. But I have O negative blood. And I needed blood for treatment of the complications I was experiencing. And I couldn't get the blood because the negative is a rare blood type. And just 2 pints I needed at the time and I couldn't get it. And I was fortunate that my brother had a friend in media who made an announcement on national news, right? And that was my first introduction to the challenges of getting blood in this country, right? And even in starting to get the blood transfusions, Dr. Waveney Charles recognized that my body was hemolyzing the blood that I was receiving. And she said this wasn't making sense for me because I was already having so many challenges getting it. So I was the first patient and one of the first patients in Trinidad to use hydroxyurea. She told me about it. She told me to do my own research about it. It wasn't available through the public health system. I bought it privately, right? So I've been on the drug for 22 years. And I saw almost immediate results in the sense that I stopped having, because I was having frequent crisis at the time. And I stopped having frequent crisis. And even when I had crisis, I didn't need morphine. A lot of it was controllable at home, right? It started there, and then starting to look at my results. When I started to go clinic and see my results, I started seeing my hemoglobin levels rising higher and higher. To the point at one point at some points it went over 13. Right now, 3 years ago, I had an aplastic crisis. So my HB went from between 12 and 13 in no time. When I was admitted to the hospital, they told me it was 7, right? I was just feeling really weak. I was vomiting and I didn't know what was going on. I took myself to the A&E. From the time the doctors told me my hemoglobin was 7, I told them, well, something has to be wrong there because my steady state is at least 12, right? 2 days later, it was 4. And I couldn't get the blood that I needed. At one point, I told my parents I didn't think I was going to make it. You know, and I couldn't even see my children because, you know, children can't come into the hospital. You know, I was in a depressive state because of that, and I knew the challenges of getting blood, and it was recommended that I needed at least 4 pints of blood. It took me a week to get that blood, and I was lucky to survive that week. I even collapsed while I was in the hospital, just going to the bathroom. Luckily, my dad was with me, but I collapsed after urinating, and he caught me and had to lift me back to the bed, right? But you know, that is the situation that some of us face. And I see some of my friends in society who have thalassemia. Sometimes I go clinic and I see them sitting to wait just to get a blood transfusion and to be told halfway through the day, they don't have it. And sometimes they do that 2-3 times in a week. So yes, that is part of the reason why I'm so passionate in terms of getting involved in blood drives and encouraging voluntary blood donation. And I will support Dr. Charles all the way in terms of getting this program implemented in our country because it's needed.
Thank you, Kieran. Thank you.
Thank you for sharing that, Kieran. I know it must be very painful.
Okay, so we are on to our question and answer section. One of the questions we have, many researchers have noted that the Caribbean has the highest incidence of STD after Sub-Saharan Africa. Yet many of the countries don't have a newborn screening program. What are your thoughts on this? Any of the panelists could take a jab at it?
Well, my dear, I don't know if that's a question or a comment, because the benefits of newborn screening, I don't think need any discussion. The benefits of newborn screening are clear. Dr. Olayemi described his outcomes in Ghana and other places. In Jamaica, once babies are diagnosed, babies with sickle cell disease are diagnosed at birth with sickle cell disease and given comprehensive care, which includes penicillin prophylaxis, vaccinations, and educating the caregiver for palpation of the spleen, the under 5 mortality with the intervention of newborn screening and implementation of comprehensive care, under 5 mortality for sickle cell babies is no different than any other baby being born without the disease. So and this is in the background of You see the under 3 mortality or the under 5 mortality in, say, Sub-Saharan Africa and so on. So the benefits of newborn screening cannot be overstated. Why I jumped in here to answer, because I know through CARIST, one of the main agendas for CARIST as a group of researchers and clinicians and practitioners is to engage governments and groups like yourselves to enable and help with newborn screening. Whereas some countries have come on board, Antigua, and it really takes us 1 or 2 passionate advocates to do so. Now, Tobago, you know, has been having newborn screening for years, and Trinidad, for some reason, just doesn't take us on. Barbados, where CARE, which is where I work, the Caribbean Institute for Health Research, as well as we are strong members of the board of CARIST, Barbados won't do it. They say the numbers are so small, we're not really quite interested. So really need to find, I think, 1 or 2 passionate advocates. It could be a parent, it could be a patient, it could be a physician or a nurse, to just push and get this done, you know, because facilities are there training. Dr. Odame himself knows through the SCI, that collaborative, you could say more on the newborn screening challenges in the Caribbean as well, Dr. Odame.
Yes, I think when you look at the Caribbean, you have small, multiple islands, small populations. Even in the United States, not every state has its own newborn screening laboratory. I mean, they all pull together and send, you can take the blood sample and filter papers and mail them. And my vision, looking at a place like the Caribbean, if it were possible for all these countries to come together, and if it was possible to have a centralized newborn screening program, it means the unit cost of doing the tests for each country is going to go down, because it's an economy of scale. And that's why certain states in the United States, rather than set up their own system, ship it to the other, because it's much cheaper. The volume is higher, it's cheaper, you don't have to set up the system. And to me, I think we need to set up systems. Dr. Charles talked about blood donation. It's a systems issue, and it will involve culture change. That is hard. That is very difficult. You don't just throw money at it and it vanishes. No, you've got to work at it, and it's so hard to do. And to do that, being together, banding together, all the leaders coming together, I think will be a very potent force. And in my experience with the SCI initiative, we're trying to get it done in St. Lucia. Again, it's a small country. It makes it even more challenging. The cost of it, setting up your own lab and all that, it raises the cost per test. Ultimately, whatever we do, we have to make a health economic argument. I believe that all the countries in the Caribbean, because there's no universal access to screening and to hydroxyurea therapy, it's costing the health system more. It's impoverishing some parents. It's reducing productivity of skilled, talented adults. It's causing early mortality. Who knows that some of these people who are dying early have the skills to transform our society. So we need to begin to make a cost efficiency argument as well. And to say that by not responding, our countries are losing out socially, economically, and the future of our generation is being compromised. So systems change is the hardest thing to do. And what I will encourage our organizations to do is team up with other organizations that have similar goals. And I like Dr. Charles's point about NCDs, because that's where the global investments are going. In fact, the WHO now is moving in direction of, I don't know whether you've heard about it, it's called PEN+. It's a package of NCD interventions, and they are including sickle cell disease into that package, so that countries will consider sickle cell disease as a chronic disease and include it in their packages of intervention. And because they are already doing that with other diseases, bringing it together is much easier to do. So in our advocacy, we should avoid setting up standalone systems for our blood disorders, because if you put them together, they are still rare compared to the hypertensions and the diabetes and the cancers. They're still not as much. But if we try to team up and take opportunities to foster similar goals, like strengthening the system of blood transfusion, which cancer patients need, which all other patients, trauma patients need, all other patients need, then I actually will be building a system that's going to benefit our patients. It's so hard, advocacy, but it's coming together. And what I worry, because I've been involved in the Global Sickle Cell Disease Network, you go to small countries like Ireland, there are several groups for sickle cell disease. You go to Nigeria, there are countless numbers of advocacy groups. We haven't found a way yet of coming together, of uniting. And in the SCI initiative, what I always anguished about was how the Caribbean countries are so small. And even travel between the islands, it was easier to go from one island to Miami than travel in between islands. That's a challenge. It shouldn't be. So it makes it difficult to do pan-islands, pan-Caribbean initiatives. And I think that's what is needed to really move our leaders to take the systems changes that is going to benefit all Caribbean people.
Thank you, Professor Odame. And as Professor Odame was talking, I'm saying to myself, the Prime Minister of Trinidad and Tobago is part of the CARICOM initiative. And it's probably something that we at the SISBD needs to lobby him with inherited blood disorders and blood donations. You know, so we should really take charge and take care of what we have here that we can use as you would say, as a weapon to get ahead in what we need to have done. Thank you very much, Professor Odame. Any of the other panelists care to make a contribution on that?
Yes, thank you, Prof. I'm glad we see eye to eye in the points about collaborating and hopping aboard a moving vehicle rather than trying to start a vehicle for the first time. And it's the facts of life. You find what is fashionable, what is catching attention, what is getting publicity, and align yourself with it. This is not storming or hitchhiking or anything, but it's the surest way forward. And please, in your enthusiasm to support the development of blood transfusion services, please do not fall awry of the definition of beneficially voluntary blood transfusion services. Voluntary that confers into benefit is voluntary and non-remunerated. If one donates and gets a credit that says you could reclaim it later on, that does not have the same effect. As a matter of fact, it has the reverse. Because it might have been somebody claiming a credit that denied Kieran, God forbid, his transfusion. To put it very squarely and bluntly. So the first thing we have to do, and I say we because I've now accepted your offer, to take it forward and say that this definition must be changed and we must empower our community, and we're doing it. And I take Prof's point about culture change, but I'm a convert. I don't think there's anything like culture, there's behavior. And behavior is what is requested or what you pigeonhole into doing. And if this system dictates that you behave in a certain way, then you behave in a certain way. And it's not to say it's a culture. Because if you went to somewhere else and the only way to behave was X, then you'll behave in X way immediately. So my voice views might be a bit extreme. I don't think so, because I've held them for a long time and I hold them dearly. That we need to change behavior. But we need to define behavior and demonstrate behavior as well. And I keep raising the example of the Blood Donor Foundation we started at the UWI. So it's nothing to do with culture. All these students were told was the facts of the matter. It was inculcated in their curriculum. They taught about it, did research, they saw for themselves. And they went and they actually donate blood and they don't claim anything in return. And they see the benefits and they keep coming back. They keep coming back. And what the other systems do, as a matter of fact, and I'm sorry for spending so much time disproportionately on that, but it's close to my heart, huh? Because I really felt badly in England when it was suggested that the people from the empire don't contribute anything to the community. And it spurred me to investigating why, which I have done, which has made me somewhat more irritated. But suffice it to say, the power is in our hands to change behavior, and that culture is behavior. Thank you. That's all I'll say for the afternoon.
Thank you very much, Dr. Charles. I have a few more questions. Many of us are referred to other clinics for screening for eyes, renal function, cardiology, orthopedics, and such like. Should we be referred for mental health screening too? Any of the panelists care to take a jab at that one?
Absolutely.
I'll jab quickly. I think anybody with a chronic illness should have some modicum of counseling and support. And specifically with sickle cell disease, I think it could be a sickle cell disease or thalassemia, the chronicity of it. And the whole thing about young people being in and out of hospital and being socially deprived and being in pain and having strong medication, disrupted lives, and so on. I think, yes, but I don't think it should be a question of referring when problems arise. It should be part of a comprehensive care program. Because there are stigmata attached to being referred to the psychiatrist. Whereas if there's a counseling service within the hospital, one to pick up these things. And it's quite, I'll tell you all, quite an example. When I was there, well, not fleetingly, we had started to bring a counselor, a trained counselor to Ward 44. And in fact, this lady became quite attached to a lot of the patients. And I think she was from Ireland. So of course, social services are quite advanced there. So she picked up on things and did the appropriate referrals. But again, the cultural difference, and I'll say cultural in this sense because it's how one grows up and behaves over a prolonged period, didn't necessarily allow her to interpret some of the signs. But she was very astute and could detect like there were problems. And there was one young lady with whom I'd become very close in the clinic, a good friend, and she was sickle cell disease. And then she'd done some time in prison, during which time we didn't see her at all. Even though when people have problems in prison, they bring them to clinic. I do know that. But she wasn't seen for the time she was in prison, suggesting that there was something outside the prison walls that was probably provoking a crisis. And as soon as she came out, she started having these recurrent admissions again and would not respond to anything like hydroxyurea or so on. And speaking to her, because I spent some time chatting with her, it turned out that there were serious domestic issues involving her and her baby, who was born under unfortunate circumstances, and the father of the baby. So there was constant infighting. And then one day I read on the papers that this young mother was found murdered in the area in which she lived. And it was her, and there was underlying it all, a history of abuse and social discomfort. So if there's an ongoing and inbuilt counseling service in the hospital, we could pick up these things early and perhaps address them. But there are serious problems. We did some research in 2000 and very early 2006 and found that most of the patients with sickle cell disease in the clinic were depressed. There's a score to measure depression. You know, sickle cell disease, among all the chronic diseases, was most linked to depression. Oh, I promised to stop at the last one. You see, Karen, you don't make me talk, you know. Next thing you're complaining when I turn.
Thank you, Dr. Charles.
That's what you're here to do today. Oh.
Going on to another question.
So I think Dr. Asnani had something she wanted to say about that point.
Yeah.
Dr. Charles has said it. I totally agree that screening for, and there are very short screens that can be done in clinic, you know, while a patient waits to get seen. Depression is important. Every chronic disease is associated with higher levels of depression, and sickle cell, just as you said, Dr. Charles, much more, almost a quarter to a third of your patients may be having, you know, likely to have depression. So quality of life, self-esteem, so many issues. Yeah. And adolescence, that's a key time period for persons with sickle cell. They really need to have that kind of sustained attention. As Prof. Odame said, you know, this is where they are developing to become, you know, critical members of our society, critical contributors to our society moving forward, and they need that support. So absolutely, no brainer for me.
Thank you, Dr. Asnani. Next question on the list. What do you think we can do to educate doctors about sensitive intravenous siting to prevent medically induced ulcers? Panelists?
Sorry, I promise silence, but I have to answer that one. Because I'm heavily involved in the training of the medical doctors. And we do seek to introduce things like these technical skills into the curriculum. I think that more needs to happen, and the input needs to be more than from the lecturer and academic staff. And one of the things that we have done up at the university, I invite members of the clinic to come in and teach the class for me. Yes? And they get a feel, and for example, how the difficulty with access, and this one did this access here, and to put it, and I think it gets some, it's more reach than saying, putting in a book that don't put the IV access at this point or that point. It really helps a lot when I always say the patients, I don't want to call you all patients, but you all are the best teachers and instructors because you have to present the situation with passion and full knowledge and with respect. But so we have to participate. It's like I'm participating in education.
Yeah.
Participate in it. And there wouldn't be young people like yourselves, you know. Young people like yourselves, they wouldn't be offended or anything. Just come and sometimes really generally don't know.
Well, I do think that we have a reasonable pool of patients who are willing to do such things. And especially now that we're working in a virtual space, I think it's, there are a lot of opportunities to have that happen.
Yes, but you can't talk too much like I'm doing, Karen.
Yes, I understand, yeah.
Professor Odame? Okay, go ahead.
If I may be a little provocative here and give you something to think about in the future. IV access is a technical skill. It is technical.
Mm-hmm.
Many, many years ago, in the UK, there was an uproar when one leading teaching hospital decided to train technicians to take the saphenous vein for a cardiac bypass instead of using doctors. And they had done their research and realized that if you recruit somebody and all they do is to sacrifice the vessels, get them clean and ready for the surgery, and that's all they do, they get slick at it. They get so good at it. And they're so good that compared to doctors who are now learning or don't do that all the time, they do many other things, you get much more technical quality in what you do. And that began to change the idea. So now you have phlebotomists, you have nurses who are trained in my hospital. I bet you those nurses are better than doctors at getting it because that's what they do all the time. And so I think moving forward, I know that this is slowly beginning to come to low middle income countries, that IV access in some patients can be technically challenging if that's not what you do all the time. If you do it only, even surgeons will tell you, if you don't do the operation a lot of time and you do it only rarely, your skill at doing it dwindles over time. And I think that's what happens to doctors. And so systems should think about whether in very heavy areas where access is a problem, perhaps training this cadre of nurses may be a good thing to do. The other thing I would say is that caregivers need to listen to patients. The patient tells you, this is my good vein. And they're telling you that from experience, that is the only one that is reliable. You ignore that at your own peril because you will fail the other side. So also communication between patients and caregivers. I mean, the partnership, I think, Dr. Charles, we are talking about behavior and culture here. I think medical care should now be seen as a partnership between the caregiver and the patient, with the patient at the center of the care. So the patient says, this is what works for me, believe it, because from their experience, that's what works. And I think a combination of these new ideas might help lift the burden that patients face when there's multiple IV access, IVs that extravasate and cause ulceration and cause a lot of harm to them. I think patients should be empowered to speak out loudly and begin to say, hear us and listen to us.
Thank you, Prof. Thank you, Prof. We definitely will agree, those of us who have had many hospital visits, that when we have our caregivers listening to us, because we are the PhD of our bodies, when they listen to us, then the time that we spend, whether it's in A&E or in the hospital, it is shortened greatly, because they have listened to what we are telling them, our bodies are telling us. So thank you very much for that. One question that came up was, what are the greatest risks that carriers or persons with a trait are exposed to? Panelists?
All the evidence suggests that if you're a carrier, the only thing you'll be worried about is exposure to extreme, and I say extreme, and this has been studied actually in the US Army many, many years ago, when they actually discovered that those people who were carriers who had suffered heat stroke, had suffered complications, it was because they were exposed to unconditioned extreme exercise for which they had not been prepared. And in fact, that discovery led them to say, it's not good for anyone, whether you are a carrier or not. So in the US Army, they changed their whole approach that you have to subject them to a conditioning process. So you go stage by stage in exposing them to extreme conditions in terms of temperature and in terms of oxygen. I think there's been a lot of research now going on about carriers, that carriers may have some complications that are associated with being a carrier. One example is having a bleed in your kidneys that may cause some problems, some eye problems. But I think the fact I want to make here is that the longevity of carriers are exactly the same as non-carriers. And that although they may have some issues under certain extreme conditions, I think if you're a carrier, I don't want you to think of yourself as being a patient simply because you're a carrier. I think medicalizing carrier status will be a mistake.
Thank you, Prof. I have to jump in here because this struck a raw nerve. I think one of the big things to which I said very openly as well, to which sickle cell trait carriers are exposed here, is discrimination. And the Army, for example, has a policy of not accepting people with sickle cell trait. And I've written several times on individual people's behalf, and I've got a response sort of justifying it, saying exactly what our Prof. Odame said there, that they justified it because of the extreme training conditions. But if conditions that extreme to cause problems in an AS patient, it'll cause problems in anybody. So I think that is something that needs to be addressed, and could be part of your advocacy, because I've had, I'm not exaggerating, people come in crying to me. Say, Doc, look, I am AC and I'm told I can't join the Army. My father is in the Army, yes, and it's what I've always wanted to be. And he went further and said, Doc, what do you want me to do? Lock somebody's neck? You understand? So it's very distressing. And I think, Kieran, you should put that very high up on your list of advocacy matters, huh?
Yeah, well, we actually did.
But that's it, research it yourself and see what the policy is in all the other countries.
Yeah.
Yes? And then you could ask, what is the policy here? Yes?
Well, I do have a coworker currently who gave me a similar
Sorry?
story. I do have a coworker, somebody I work with presently, who gave me a similar story because he wanted to enter the Coast Guard and he has the trait.
There you go.
Right?
This is discrimination.
Yeah,
yeah, so you all have to pick up that. You see, I can't go quarreling for you, Karen. Let's see, but let's say what is Charles HB? You understand?
Yeah.
Let's say, but Karen never complained.
But if Kieran's complained, Dr. Charles can.
Dr. Charles, I think I agree.
Yeah, then we support it and say I'm in support, but the advocacy must come from you young ones. See, the most credible.
I think
Dr.
Dr.
Olayemi.
Yeah, I was going to say I agree completely with Dr. Charles and Prof. Odame that there's been this slow move towards trying to medicalize the sickle cell trait. In Ghana and most of West Africa, 25% of or more, between 20 and 30% of the population have the sickle cell trait. And if you intend to say that is a disease, then the health system is going to break down. And people with sickle cell trait are as healthy as they can be. if even like rightly pointed out, the kind of stress that you need to put a sickle cell trait person to before you see a sign of any medical problem. I'm sure somebody with AA2 will also have broken down before then. So
that is so true. So true. Even if you're not going into the army, what about getting simple insurance policies for yourself? It's such a hassle when once they figure out that either you have a trait or you have sickle cell, the rates go up from $10 to $1,000 if you do want a policy. So there is a lot that we have on our plate to do to get help with, but we will be calling on you all. There's another question that is asking that if prolonged use of whether it's morphine or petadine can hamper, let's say, a person getting pregnant.
May I?
Sure.
Well, I don't think hormonally, no, but I would think the reason why there's the need for prolonged use of opioids might cause social and problems that lead to inability to childbear. And it does suggest very severe disease as well. So it'd be more like, probably like the severity of the disease itself causing any fertility problems.
Yes, what I will say to that is that there's no direct relationship between opioid use and infertility. It may be that the opioid use is reflecting some other underlying problem which could potentially affect fertility. So I think I agree with Dr. Charles's response, but I think what this questioner is asking, whether there's a direct relationship between opioids and infertility. And I don't think there's any. I haven't read of any, and I haven't come across any evidence of direct relationship.
I agree with that as well. I agree with both of you. I have never read of it nor seen it as any direct relationship.
Thank you, doctors. Thank you very much. Another question, I think this one is for Dr. Charles. I have read that hemophilia was considered a royal disease. Do you think that the robust transfusion system in the UK is based on its occurrence? And to some degree, if those in authority were affected by these disorders, the system would be different?
Thank you for the question. I don't think the attention that hemophilia got was much to do with it being a royal disease, although I've heard about the link as well.
Mm-hmm.
And about those in authority being afflicted with the disease, responding differently. I think the broad framework for an appropriate response has to be there for them to respond appropriately. For example, if I'm in a position 2 and my relative requires commodity A or commodity B, I'll get commodity A. So that doesn't require me to change the system that prevented getting commodity A difficult. So I think it really needs to come from, I don't want to call people the ground there, but from the people who directly affected, and it must be put forward reasonably, dispassionately, and where it can't be disputed. That so-and-so is required, and then people have a voice. It's difficult to ignore a reasonable and very widespread voice, and it's difficult and a persistent voice as well. But it must be polite. That's why I think that inquiries must be made about these things I highlight. I don't want to end up on papers tomorrow and say, Kenneth Charles said, huh? I see Mr. Zeddy is jotting things down. Huh? our hematologist buses mark at our conference.
No, Doc. No, Doc.
Okay.
If I may.
We have a hand up from Ms.
Dr. Kiran, Dr. Odame has a response.
Go ahead.
Can I go ahead?
Yes, yes.
Right, just some advice in my travels around the globe, interacting with sickle cell advocacy groups. Just some note of advice. I think that would be helpful.
Sure.
Yes, the patients who live with the disease and the families who are affected by the disease are your most authentic advocates, but not they alone. It is good to include in your advocacy others who don't have a personal experience, don't have a family experience, but nevertheless understand what they see and what they hear. And they are influential people in society that can embrace the advocacy and can be a force for good. In some countries that I've been, sickle cell advocates have been they've suffered so much that they think nobody else can make their case except they themselves. And I think, again, widening the base, because otherwise what politicians do is they find ways to ignore them, say, oh, they are suffering from their disease, they are angry, they only see their issues. I think that can be, that argument and that pose of governments can be broken down when you have other prominent people in society that say, no, it isn't. They are citizens. I don't have that personal experience with the disease, but I see what I see, I hear what I hear, and I think they deserve to be heard. So widen the tent, bring in more people, and I tell you, it will only be for good, not for the worse.
Thank you, Dr. Odame. Thank you very much. Kiran, I think there's one more question I have.
Okay, go ahead.
I know it would be posed to Dr. Asnani or Dr. Charles. However, anyone on the panelists that is willing, please feel free. What can you do to help the SISBD-TT to get the Ministry of Health to adopt a standard care protocol for persons admitted to the emergency department or even warded, especially as there is no guarantee of hematology consults, even where it is available? Dr. Charles, Dr. Asnani?
Yes,
I think Dr. Charles can begin first, since he knows the system.
Oh yeah, sorry, and I should answer. Now, I recently rejoined the Ministry of Health in a capacity that sort of includes hematology care throughout, the hematology systems throughout. And several things happening. We're in the process of, well, increasing the numbers of hematologists we have. And in addition, we started a training program in hematology at the University of the West Indies. So as a matter of fact, just today I'm going to meet with the respiratory physicians to work out a national protocol for managing clots in the lungs. But that's how it happens. And we could as well propose a national guideline for managing patients with sickle cell disease. Yes?
Yeah.
And of course, in fashioning it, we'll have to get what are called stakeholders together. But that could be a double-edged sword when too many people involved. And yes, you want to be very concise and to the point. Yes? So you have to know what are the issues that affect you, what are the things that concern you. Because you can't go and be writing up a protocol and you're not aware of the things that matter most to you. So I would think Karen or whoever of you could drop a line and say, further to this conference, these are the issues that you could send it to me. Among yourselves, these are the issues that concern you. And that would be a template for moving forward. Yes? Great. Because it's a big problem. Like I was telling you on Wednesday, Kieran, that same day, my colleague from the UK had emailed me to ask what is our situation with getting analgesics to sickle cell disease patients, because they're having a lot of problems in the UK. So this could be the starting point. Yeah. If you could lobby your members and see what are the issues very specifically. Yes? Yes. And we could then bring them forward and address them in a national guideline.
That's a great start, Doctor.
And that could happen within a couple of months, huh?
Yeah.
We have to keep reminding me, Karen, at home.
We definitely would.
All right.
If I may jump in as a sister Caribbean nation, Jamaica, maybe because of the presence of the sickle cell unit in our country for the last few decades. In the last few years, definitely there have been a few successes for us that, you know, again, I was very happy to hear Dr. Charles speak about collaborations, Prof. Odame speak about collaborations, and all of us have spoken about that. I also believe we don't have to reinvent the wheel all the time. So there are a few things that the Sickle Cell Unit, along with the support club and so on, have been able to achieve, which is buy-in at the Ministry of Health and Wellness in Jamaica. So we actually are part of the National Chronic Disease, the Non-Communicable Chronic Disease Panel of Illnesses. So sickle cell disease has been placed under the NCD guidelines and so on. So we already have entered their books as such. The unit itself has published guidelines, clinical care guidelines, which are like a little handbook for doctors and interns and residents, is placed in every primary healthcare center. Our first guideline was published in 2008, and we did a revision in 2015. So these are easy guidelines, you know, that work for us, because not everything that works in the UK or in the US works for us in Jamaica. For example, the blood issue, we have a huge problem with blood supply. And as a result of that, maybe as a result of that, and for many other issues, chronic blood transfusions are not a standard of care for us for the most part. We use hydroxyurea, and that's another conversation. But engaging with the Ministry of Health, along with the Support Foundation and the unit, as you said, Dr. Odame, you know, different stakeholders coming together. So we have inserted ourselves in the ministry's national program for providing care for NCDs, okay? So guidelines are available. I think Dr. Dame, you know quite well about our guidelines. I think SCI has had many talks around the guidelines as well, and they are very much available. Our ministry has bought into it literally, and they have bought them and placed them within all the primary health care facilities, as well as hospitals for inpatient management and outpatient management. And the other thing, Dr. Charles, is that I know the CARICOM meetings, the Ministers of Health meetings also occur. So my current Minister of Health, since he came on, is really a somewhat of a star in my country, especially with our response to COVID. But even before that, he created a program called Jamaica Moves. And you might have heard of it because it has now been taken up by other ministers of health who are his peers. And now you hear Caribbean Moves, right? So the movement program, you know, this is to get people more physically active to fight the burden of NCDs. So I think if there can be advocacy at the level of the ministers, I know when we used to have our CARFA, what used to be the CHRC annual meeting, which is now the CARFA annual meeting, one day of the meeting, the ministers of health actually all came together and discussed that. And I know through various groups, we would put forward important public health concerns at that. So ministers would listen to their peers from other countries. I don't know who has the push for that kind of thing, Dr. Charles, in your country, because that can be another avenue. So I think there are different avenues to place yourselves. Jamaica has had some successes, and especially in the last 3 years. This year, for the first time, for World Sickle Cell Day, which is today, awareness took place for the whole week. It concludes in a few hours, and I have to join another panel for that. And the Ministry of Health actually took that on. The minister and the Ministry of Health has actually put together a group which is called the Sickle Cell Technical Working Group, which is part of the NCD group of the ministry, and it is led by the ministry and has representation from the Sickle Cell Unit and the Sickle Cell Support Foundation, the Sickle Cell Trust, etc. And it is really doing a lot of work regarding care for persons living with sickle cell disease in the island. So I just wanted to name a few of these initiatives that are showing success in Jamaica, and how, you know, it has taken us many years to get there. It has taken us, but we seem to be in a good place, because from 2015, we were allowed universal newborn screening. So now we have island-wide newborn screening. And it is initiative like that through different avenues and collaborations and really networking and strengthening as groups coming together, advocacy groups, not just researchers, not just clinicians. Last but not least, the Sickle Cell Unit, along at the behest of the ministry, does, for the last 3 years, we do a lot of training of healthcare providers throughout the regional health authorities, etc. And we have, for the last year, I think, have started the ECHO program in Jamaica as well. You're aware of the ECHO program. And this is a monthly discussion program. We did 10 sessions, 10 ECHO sessions speaking to newborn screening. And now the 10 ECHO sessions are going on early childhood care, and it will move forward into adult care as well. So there are many different achievements that we have had, and I think they are bringing a lot of shining the light on sickle cell in public healthcare systems to improve care for patients. So just to give you some ideas there and see how we can, if any help is needed, then we are there.
Thank you, Dr. Asnani. Thank you very much for that. Kiran, do you have any further questions for our panelists today?
I had two quick questions.
Go ahead.
One for Dr. Charles. As far as you're aware, is there genetic counseling available for people who, like a couple who both are aware that they have AS? And where is that available? And then for Dr. Olayemi, you shared some testing that was done in schools in Ghana. Could you share what type of test was that? Was it a rapid test or what? Thank you.
Yes. Sorry. What's your last name again? I have to address you very properly.
Esdale.
Ms. Esdale, yes. I do believe there's a formal genetic counseling service as far as I know, but it's a very dicey thing, because it goes far beyond saying you are AS, and there's a 25% your child will have SS, because several things you could cause disquiet. I'm thinking about how people are. You could cause problems if it is discovered, depending on how the child turns out. For example, if the child doesn't have nothing at all, and then this one accuses that one and so on. And the response to the information is different. For example, the people may have somebody they know who has sickle cell disease and decide to go on. Yes? And then one worries, I worry about the ethics of putting that in the way of two young people who might be in love and want to have a family. And in so doing, prevent the birth of somebody as lovely as you or Karen, you understand? So so there's nothing formal, and as far as I know, but I think it needs to be a very intimate thing if it is done.
Okay, because I was just, because Dr. Olayemi in his presentation gave some options. There are options for a couple in that situation, such as
yes,
IVF or fertility clinic and so on. So I was just wondering if that sort of conversation is had locally.
Well, yes, if you do have it, if you meet the somebody, you could tell them about it, but really it's something that is not readily available. And forgive me for getting back to it. I quite appreciate all the things that Dr. Olayemi pointed out to us, all the possibilities, yes? But I do know that things need to be fashioned out structurally from the base.
Yeah.
And then when you've established a base, then you build on the services. And I know that, don't take this the wrong way, I think it's probably a trait of a management trait, that if one could be convinced to provide something expensive that catches the general eye, it could remove attention from addressing something that is necessary. Yes? And resources, well, it could divert resources. And then as well, deprive you of the moral authority to ask for what was a basic need. They will say, but what's her name again? It's Miss Esdale?
Yes.
Yes.
But we gave her this so-and-so, what's she asking for now? So just last month, we gave her $2 million to do so-and-so. She comes back this month asking for basic services.
Right.
You understand?
Yes, yes, thank you.
Sorry, I'm pretty cut and dry, so
No problem. I appreciate it. Yes.
Yeah, so continue from where Dr. Charles stopped. There's a West African Center for Genetic Medicine at the University of Ghana. And actually, we are starting a short course training genetic counselors starting from Monday. So genetic counseling is something that has been lacking in most of our health facilities. And we've realized that we needed to do something about it. So a short course, I think it's a 2-week course, training genetic counseling counselors is starting on Monday. One of the things that COVID has done is that it's made it easier for us to organize more discourses virtually. So it's going to be a virtual course. Then the question you asked me, the test that we do is not rapid. The rapid test kits are not for sickle cell disease. It's not yet approved in Ghana. I know there are some tests and trials going on currently, but it's not yet formally approved. So what we do is that we collect the samples from the students, label it properly with their names and all that, and bring it to our lab. We have a small lab at our clinic where we do the sickling test and hemoglobin electrophoresis. It's only after this that we issue out the cards. Then we'll go back, we book another visit to the schools where people who have sickle cell disease from our test and those who have the traits are counseled properly by our clinical psychologists before they are given their cards, while those who are normal are given their cards and just receive the general counseling that's offered to the school at the beginning. So that's what we do. Thank you.
Thank you very much, Doctor.
I have a couple more questions from one of the members. I have had many times when citing of IV accesses, doctors refuse to listen to my instructions. I gave up many times. I have to take this for granted, so much so that I lost my finger as a result of a citing. Do medical students practice on themselves? Because it seems like some believe it doesn't hurt. They aren't empathetic. Anyone care to take this one? Does medical students really practice on themselves, as we sometimes see on television shows such as Grey's Anatomy?
Not as far as I know. I mean, it's kind of difficult to cite an IV on yourself, but I know exactly what you're saying. I can understand exactly what you're saying there, that maybe empathy, even though we might think is innate and anybody who wishes to be a healthcare provider should have that. How do you teach people to be empathetic? I wonder what are the ideas? Maybe those should be a couple classes. There are definitely a lot of soft skills that are not taught in medical school. You know, medicine and learning in medicine is like an apprenticeship. And if the seniors show empathy then and hold these students up accountable, then it will improve. Dr. Charles, you are directly in the FMS as well and teach a lot of medical students. How do you think it's being managed? Because it's all about students to be empathetic. Students and doctors, I mean, because they're the ones who are going to become doctors.
I'm sorry, was something directed at me?
Yes.
I was saying, do you teach any empathy at medical school?
Or teaching empathy. I think it's one of my pet peeves about medical education, because I think there's some things that can't be taught. There's some skills that are acquired by observation, and separating them out as a topic or a heading or a course could have the opposite effect. And unfortunately, it's just learned by observation and example and doing. So there are courses that teach it as professionally ethics and communication and so on. But I don't think it has the same effect as people getting involved and doing. So again, I am a very firm advocate for like medical students being involved in patient care from the first year and get involved with patients and their family from very early and understand the full, oh Lord, Mrs. Eddie's eyes wide open. You don't like the idea?
Oh yes, Doc. I am all for the learning from as early as possible, because I have had many experiences.
Yes. So these are the kinds of things I advocate for, because I think it's all about dealing with people and you can't teach your compassion on a blackboard. Yeah. Or as a module.
If I may add some comments to that, this is not only something that happens in Trinidad or the Caribbean. This is universal. In fact, here in Canada, it's been an issue that the population feels that increasingly the current generation of doctors are losing the empathetic approach to patients. The doctor is sitting in front of a computer, doesn't even make eye contact with the patient, doesn't engage in a meaningful conversation. It doesn't appear that they are listening to the patient. And so patients are saying that, what kind of doctors are we training for in this generation? And a number of steps that medical schools in Canada have taken. I think Dr. Charles alluded to it. A person who will be a good doctor is not necessarily the person who's got the highest grades. And I think that mistake has been made for some time. Yeah. That the person has got the highest grades, goes into an interview, he's got the highest grade, and then is admitted into medical school. So many of the universities have an interview process that actually has been validated, can identify who has empathy and who does not. And those are the ways they are sifting, even right from entry point, because there are some people, no matter what you do, no matter what training you give them, they just don't have that level of empathy that will satisfy patients. So right from the onset, We want to know whether the tools of selection are really identifying those who really have the empathy that training deserves. The second very important thing is that in determining how well they are doing, their patient's perspective is going to be taken into consideration. So they've seen a patient, the trainer goes to the patient and said, "Oh, you were seen by Mr. Brown. How did it go? Did you feel that he was listening? Did you feel that he was empathetic? Did he really listen to you? Did you feel you had a good contact?" And that patient's perspective is going to go into the evaluation. So the field of medical training is moving in that direction because the population is complaining that empathy is being lost. We're using guidelines, we're using just algorithms, we don't listen to the patient, everything is computerized, we're looking at gadgets, and the patient doesn't feel they've had an encounter with a human being who understands them. So this is a universal problem, and trainers of doctors have to grapple with the challenge.
I think also, I don't do much teaching, but the only course I teach formally is one I'm extremely passionate about, and that's why I keep teaching it. And it's called physician-patient communication. So it's all of these things, you know, and I hear all kind of stories from my residents who I'm teaching, who believe that quality interaction means longer interaction, and they don't have time for that. Doc, I have 100 patients waiting on me. I don't have time for hand-holding. And in my 6-week course, I have not had a single one who doesn't change their mind about quality not being equal to quantity. So, but I also think, so that is important, Dr. Odame, as you say. So I have seen and I have pushed for my faculty to see if that course can be given to all levels. I mean, you have people in the DM psychiatry program, in the doctorate for psychiatry, and they know such communication modules in that. So I think it is not innate for everyone to be empathetic or have good communication skills, but it can be learned if you want to. And if nothing else, you know, what don't medical students want? They don't want to fail. So in our OSCEs, in our clinical exams, those are skills we value highly. And we do the same as what you're saying, which is ask the patient's opinion. Definitely when I conduct clinical exams, I will always ask the standardized patient or the real patient after the encounter, what did you think of that doctor's communication with you? Did you think she was empathetic? But I'm also saying, because we are here now with the society, that you need to feel empowered to speak up for yourselves as well. You know, you need to demand this. I teach this to my patients. When you go, no matter how busy the doctor seems to be, ask, what is my diagnosis? Do you know how many patients are having surgery and they don't know what they had the surgery for? Major surgery and they don't know what happened in this surgery. So we, you know, as physicians, if we are really trying with our patients, we empower them. A lot of Jamaican patients feel, oh my God, is the doctor going to feel offended if I ask questions? So we say, no, it is your right to know. You must know what's happening with you and why, etc. But I think patients also need to demand this in nice ways. Maybe, yes, doctors may be miserable or look like they're very busy people, but this is part of their responsibility. So we try at this end and you keep trying at your ends. But I do believe that if you hit them where it hurts the most, which is they need to be pulled up for you know, I think these are misdeeds on parts of physicians if they're going to end up with these kind of things. Definitely in the US and Canada, etc., there's a lot more litigation. I don't know how it is in Trinidad, but I think people get away with a lot in the Caribbean, medics, you know, and maybe if they got it where it hurt the most, it would help more. I have no patience for it.
I want to say something about that, because I think from my perspective as a patient, there's a bit of a culture from my experience in the hospital where we are mostly seen by younger doctors or interns, right? But yes, the senior officer may come in the morning, right? And with the team, but then for the rest of the day, a younger doctor sees you. And my experience when I was in hospital 3 years ago, because I didn't know what was going on with me, I didn't understand why my blood count was dropping so quickly, right? And I was asking a lot of questions and I got no answers. And I got irritated and I begged my parents to go to management and ask to demand for a hepatologist to see me, or somebody from the hematology department to see me. And up to the point I was discharged, I was not seen by anybody I know from hematology.
That's very difficult.
Yes, it is. Panelists, I see that I have one final question for you all. If you have a low blood count and pregnant, what are some of the best, are they saying drugs or supplements that they can use?
May I answer?
Oh,
okay, go ahead.
Thanks for the question. It depends on what is the reason for the low blood count, or anemia as we call it. Because the reasons vary. I think the most common is probably iron deficiency. Yes, but there could be other causes that occur in pregnancy. And if it's somebody with sickle cell disease,
Doctor, you're muted for some reason.
sorry, anaplastic crisis like what Karen is describing. But there are many reasons for anemia in pregnancy, but it should be investigated because it's very interesting. We got a lady with aplastic anemia in pregnancy. So not because you're pregnant, you're spared any other cause of anemia. So it definitely needs assessing and not just giving a tablet. You need to find out the reason for it. Does that answer your question?
I hope it does, Doc. It was a question in the session that someone asked that I am relaying on to the panel.
Okay,
well, I think we could wrap up here.
Okay.
Yeah. So, thank you very much to the panelists, each and every one of you, for spending this time with us today and the valuable conversations that we had. I would pass over to Kieran to do the closing.
All right. So I was about to say, before we close, I would like to sincerely thank all of you for coming forward and taking part in this event. From Professor Olayemi, who responded from the first time I emailed him, and to the rest of you who all gave positive responses in short order. Right, I really thank you, and I thank everyone who's been on with us for the whole week, from our very first session, Dr. Keshi with newborn screening, and even when Dr. Odame told us he wouldn't be able to facilitate us early in the week, it might have been a challenge, but it turned out good for us because we were able to get Dr. Waveney Lance to do the session, and the session was amazing, right? So even though the challenge left us with short time, it still worked out. So, and I want to also say that I didn't do this alone. I had a team that supported me along the way, right? Some people like to work in the background. Some people's faces you will never see, right? But they all supported, and some of the ideas didn't come from me. Mr. Young, right, and a lot of members of my committee pushed me all along the way. They gave me good ideas, good support, right? And I want to thank each and every one of you, right? Especially Ms. Alexander, who through it all has been facing her own personal challenges, and has always been there supporting always made herself present when she could, right? Despite the circumstances, even when her son was ill, even when she's facing her own personal challenges, right? So for each and every member of the team, I would like to say thank you.
You're welcome.
Very much.
Thank you so very much. Really, it's been a total honor for me to be part of your activities, and I'm so very proud and pleased to see the passion and the work and the strength and the knowledge that you all have. It's amazing. Heartens me very much. So thank you so much for having me join it with you all. It's been great being with everyone today as well.
Well, Professor, I will also let you know that I think on Tuesday or Wednesday, I think last week, is it last week, Renee? We met with Ms. Morat, right, and some members of her team, right? So we had a Zoom session with them, right? And we are gonna view on to the activities that are happening, I think at 6 o'clock your time, 6:30?
6:30 our time, 7:30 their time, yeah.
Yes, so we are gonna be looking on, and yeah.
Nice,
right?
wonderful.
And we do look forward to working more with them in the future.
Absolutely, thank you.
Yeah, and I would like to say a big thank you to Karen and all the members of the team for inviting me. It's been a very great time seeing you all, and I've learned a few things, and we'll meet again. And Dr. Charles, don't know when we'll meet at BSH again, but one of these days, I'm
sure soon as COVID allows.
Yeah, and we'll have face-to-face meeting. And Odame is always in Ghana anyway, so I'm sure I'll run into him one of these days. So thank you very much for inviting.
Lovely to see you again, Doc. Thank you. And thank you all for allowing me on your panel, a very distinguished panel. It's a great honor. I learned a lot from you all, and I hope I was able to make a few points that I see as important. Thank you.
And I have to say, I always enjoy participating in these activities with this organization, which is a model. I haven't seen this model where inherited blood disorders come together under one umbrella. And I think it is something that you should cherish. It's something that you should nurture. And if possible, let it happen in other Caribbean countries. Thank you very much for giving me the opportunity.
And one last time, thank you very much on behalf of the SISBD-TT and the World Sickle Cell Day team for giving of your time this week, that we have been imparted with such knowledge. Normally we say sometimes, you know, they say sicklers are junkies, but we are on a different high of the education and of all the love and all the knowledge that has been passed us over this last week. And we will be continuing into the future. Thank you, thank you, thank you all for your help and imparting your knowledge upon us. Thank you.